You can notice here that the final activation with the final sodium hypochlorite rinse is now running relatively clear. So you can see here that, you know, we're activating this and it's relatively clear. So I'm happy now that canal space is cleaned and ready to obturate. Hello, welcome to this week's Friday's clinical case. And today we are going to center our attention around the irrigation and the activation of our of this root canal we're going to do today. And you know, if you don't know what I mean by irrigation and activation, well, it's probably the most important thing that you can do in root canal, because the shaping and the obturation are of course important, but it all centers around removing the bacteria from the root canal, and that's what causes root canals to fail, remaining bacteria. So if you've never activated your irrigant before, essentially it's where you ultrasonically activate your either sodium hypochlorite, your bleach, or your 70% EDTA to remove the smear layer. And what you'll notice is when you activate this, especially ultrasonically, you'll notice the debris kind of collects in the sort of irrigant, and it goes from clear to this kind of pond sort of water type of colour or consistency. So if you've ever activated your irrigant and you do it for the first time, and you'll never not do it again because you know you're cleaning really well. Before we get on to the case, what I would say is, you know, about 50% of the people who watch these videos are not subscribers. So I'm going to get on my hands and knees here, and I'm going to beg you and say, please, if you could just like and subscribe today. It's a really easy and it's a really free way of supporting the channel. If you do subscribe, it takes you half a second just to move the cursor over to the subscribe button. I promise that each week, every video will just get better and better. If you want to bring your support even further towards the channel, we've got a membership program. The membership program is just a small monthly fee, and you get really great things with this. If you like watching these videos, where you can get early access to videos that are scheduled further on in the week, we've also got new exclusive content. We've got a fantastic root canal access hour-long lecture, and it's got loads of videos. It shows you how to access teeth. So if you could join the membership program, it'd be really beneficial to your endodontic experience. Anyway, we'll get on with the case. This is a case of a lower left 4, and you know, it's got a pretty poor prognosis, this tooth. You know, the restoration on this tooth has got decay. It's got a failing root canal. The obturation is not to the working length or well condensed, and also it's got quite a significant apical inflammation seen on the x-ray. So overall, this tooth not in the best of shape. However, you know, as you know, I mention every time, we consult these patients, we give them the ins and outs of the treatment, and in this case, this lady wants to try and save this tooth. So the first thing we're going to do is we're obviously going to place rubber dam. A lot of the times, if I am accessing a tooth that's quite heavily restored, I might access without rubber dam, but in this case, I know I can see straight away that you know, I'm not going to risk perforation with rubber dam on this case. But you'll notice here that the clamp is starting to slip off ever so slightly. So the clamp we're using on this tooth isn't appropriate. So best thing to do is just whip the clamp off and just replace it. And in this case, weirdly enough, I'm using an anterior clamp. So I wouldn't often use an anterior clamp for a premolar, but in this case, the tooth is quite small, and I feel like it's going to grip the tooth a little bit better. Of course, taking x-rays with the anterior clamp is going to be more difficult, so that's kind of a bit of a way up you need to take into consideration. And then once we've removed the filling, we can see that we've got some exposed GP, and I'm just going to have a little pick around with my DG16 endodontic probe and just see how well condensed this GP is. And straight away I'm going to use the screw and pull technique. In this case, I'm using a H file. I believe this is a size 25, and I'm just screwing in, and you can see straight away that as I pull, we can see a little bit of that GP, and when we have a little look at the access cavity, we can see some of this GP is starting to remove. And then, you know, it's just a kind of a bit of a cycle of more twist and pulling, and more twist and pulling. And what this is doing is the H file is gripping onto the loose GP cones and pulling them out. I can see here now that maybe my 25 isn't gripping the GP cones as well as we'd like. So I'm going to move up a higher diameter, and I'm going to use a size 30 H file. You've got to be careful, of course, of file fractures, so just be really, really mindful. And, you know, it's just patience and time we've got to use, and we can see we've dislodged more of the GP cones here. And I'm just going to give this tooth a little bit extra irrigant, because sometimes, as you can see here, some of the GP cones looks like they're in the canal space, but when you irrigate it, they just fall out quite easily. And then finally, we've got this kind of tiny little bit of GP left. Now, what I could do is I could just get a rotary file down there, but what I'm slightly concerned about here is churning up this GP, and the best thing we want to be doing here is removing things in one. So I'm just using this DG16 to see if I can peel the kind of GP off the canal wall here. And, you know, it's just time and patience. Sometimes you use a DG probe and it sort of flicks out quite nicely. And like I say, sometimes when you can't get these GP cones out, it's because they're quite pushed hard against the canal wall, and especially if the canal wall's like a bit sort of V-shaped, this can sort of be, you know, the rubber and the GP can be sort of lodged quite firmly in. And again, lots and lots of irrigants. It kind of goes without saying, doesn't it? If you're using lots and lots of irrigants, this can sort of remove some of all the nastiness, and you can have a little bit more vision on the canal space. And also, I do like to aspirate as well as irrigate, because this gives me more vision. Sometimes, though, this can block your irrigation syringe. And, you know, I feel like I've sort of dislodged a little bit of the GP off the wall here. I'm going to do more twisting and pulling in this case. And then once we've finished our sort of twisting and pulling, and when we look at the orifice, we can see that it's not all out. But I feel like at this point, maybe it might be a good idea for me to see if I can get to length, because I'm not getting the GP out in a one. If I know if I just get to length, I can get a rotary file down there that might help me sort of remove some of the GP cone. So we're going to just hook up the apex locator here. I'm going to use a size 10 K file, and I know when I sort of watch wind this hand file down, it's reaching the end of the tooth quite easily. So in this case, you know, I do the same thing every time. I like to push the K file out to the end of the tooth. Not too far, of course. We don't want to damage the periodontal ligaments too much. And then we sort of back it up. But as we back up the ham file, and I reach my 0 reading, and I remove the ham file and I measure it with my measuring block, we can see that the 0 reading is 19 millimeters. And I always think this is probably a turning point in any reroot treatment, because we know we're at the end now. We've reached the end. We've got the canal paintings, and the only thing we need to do now is just clean the canal space. And I'm just removing a few of the last sort of fragments. Again, just using a DG16 probe to kind of sort of dislodge the GP. And then I'm just going to attempt a bit more twist and pull with the size 30H file. You know, I'm trying to get the sort of the curls of the hand file here. To pick up the GP. It's not happening in this case. So sometimes what's a really, really good instrument to use is your own ultrasonic to dislodge some of the GP. And this ultrasonic is the lowest of energy. So it's even lower than using, say, the energy from the diamond tip endodontic tips. And this kind of just sort of vibrates the GP a little bit. But it can sometimes damage the GP and break it off into little pieces. And then once we've dislodged the GP slightly with the ultrasonic tip, I'm going to just get my size 30H file again to do a little bit of twist and pull in. And as we twist it in and we pull it out, and as we have a little in the coronal orifices, we can see the canal is nice and empty. And then I notice where the GP's gone. We can have a little look. that just around the rubber dam clamp here is our last remaining piece of the GP, which is fantastic. So another kind of step towards completing the root canal in this case. We're first then going to do a little bit of shaping. We know the working length, so I'm going to use a glide path file here at 90mm. That's a 0 reading. Lots and lots of irrigant, okay? Super lots of irrigant. And then I am going to use my 25 variable high flex, and usually this is a master apical file. This is my final shaping file. However, I just feel like I need to go a little bit higher up because I want to get rid of as much as the remaining GP as possible. But what I am going to do is I'm going to do lots and lots of irrigants and lots of activation in this case to try and get rid of any of the sealer that's sort of hanging on to the canal spaces. And then my final shaping file in this case is actually going to be a WaveOne Gold 4505 taper. Again, I don't often use WaveOne Gold, but I feel like this is a nice little file to use for when we're doing final shaping with a reroute treatment. I also use WaveOne Gold when I'm using an extra long tooth because high flex don't have extra long files. And then we always remember to recapitulate, especially it's really important if you're using a high diameter file. And then, we're ready for our cone fit. And, I'm just going to fit this matched cone here to length. And when we look at the x-ray, we can see that we are to length. We haven't pushed any of the old GP at the end of the tooth, which is really important. And we can also see here that the apical infection is sort of in the middle of where the apex is. So we know we're kind of in the sort of right vicinity here. And then while the x-ray is getting developed, I'm just going to set up my disinfecting ring here. And what I'm going to do is I'm going to get my 2% hypochlorite in one of the little wells, and I'm going to use my EDTA in another little well. And again, if you've seen a lot of my videos, this disinfecting ring is a really nice kind of point to which we can gravitate, me and the nurse, and she knows where to put things. And then we're going to pull out the GP cone that was taken for the cone fit radiograph, and then we're going to disinfect it. So we're going to put this GP cone into the disinfecting well where the sodium hypochlorite is. And then we're ready for our final disinfection protocol. And in my case, what I like to do is I like to use sodium hypochlorite as a first wash. And notice here that when we activate the sodium hypochlorite, it's removing all the debris off the canal walls. It's also removing a little bit of the sort of smear layer, which isn't heavily adhered to the canal walls. And then we just like to replenish this. And this is like a nice feeling. I know a bit strange, but it's a nice feeling to make sure the irrigant gets nice and clear. And then we're just going to repeat this step. We're going to sodium hypochlorite activate until the irrigant runs relatively clear. Now, it's not going to be like glass clear, but it's going to be better than nothing. And what we do is we take the same syringe, we just sort of decant the remaining little bits of the sodium hypochlorite, and then we suck up the EDTA from one of the wells here. And this, again, it saves you sort of placing the syringe directly onto the bottle. So this is a nice little way of doing it in a safe and clean way. And again, it's the same sort of protocol. We're going to irrigate lots and lots of EDTA. There's no point sort of drying off the sodium hypochlorite because we're using so much EDTA. We're replenishing so much of the irrigant. This is just going to wash away nicely. And also the two irrigants don't really negatively react with each other in this case. And we're just going to do it until we run clear. And then we sort of decant the last of the EDTA into the back into the well where it was. My nurse is going to get some of these paper points. We're then going to suck up some of the sodium hypochlorite as a final rinse. So the EDTA has opened up all the canal spaces, all the dental tubules, and then we're going to do that same thing again. And what you'll notice is when you're using sodium hypochlorite for the first rinse, and then it runs clear, and then you use the EDTA to do another sort of rinse, the second rinse, and then that runs clear. You then go back in with a final irrigant, and what this does is you'll notice that that more debris is removed after the EDTA. I mean, that sort of demonstrates that the EDTA is removing some blockages, and then you're doing this final irrigant. And I was actually taught not to do a final rinse with sodium hypochlorite, but I think in this case nowadays, using a final rinse of sodium hypochlorite is much better, and it's in the patient's interest and the tooth's interest to clean everything out. And you can notice here that the final activation with the final sodium hypochlorite rinse is now running relatively clear. So you can see here that we're activating this, and it's relatively clear. So I'm happy now that canal space is cleaned and ready to obturate. And then we're ready for our drying protocol. I'm using these paper points here. And again, what I'm doing is I'm just drying this as much as possible, because I'm using a bioceramic which sets in the presence of water. But what I don't want to do is I don't want to have the inside of the canal space too wet, because the bioceramic has got a tendency to wash away in the presence of excess water. And you can see here now that the paper point is nice and dry, vis-a-vis now the canal is nice and dry. So in this case, what I did forget to do is I forgot to decant some isopropyl alcohol. So I'm just going to place some isopropyl alcohol into this kind of well here. I'm going to pick up the GP cone. I'm going to just do a little bit of a shake, and I'm going to dip the GP cone into the isopropyl alcohol, and then I am going to air dry it. And that gets rid of all the kind of sodium hypochlorite which is sort of on this GP cone. The GP cone now is ready to obturate. So like I said, I'm just going to air dry it here, and I'm going to place that down. That's ready to go straight into the canal space. I'm then going to pick up my my bioceramic. I'm going to use these visco tips here, and what I'm going to do is I'm going to load the visco tip up and ready to go, ready for the final obturation. And then I'm going to directly inject the bioceramic into the canal space. Again, I've said this a million times in all my videos. If you don't have access to high magnification, I probably think this might be a poor decision to do this sort of thing. So in the case where you don't have high magnification, the best thing for you to do is just to dip it into your GP cone, and dip your GP cone maybe 2 or 3 times the length. We're then going to introduce a sterile hand file. Remember, this has been soaking in the bleach for quite a while now, and this is going to introduce the bioceramic to the working length and also stop any sort of vapor lock. And then very, very, very slowly introduce the GP cone into the root canal. And what you don't want to do is you don't want to push this down too strongly, because you're going to need to make sure there's a little bit of space for the sealer to vent, because you obviously don't want too much extrusion, because you think about maybe the mental nerve. And then I'm going to remove the excess with my heated plugger. Again, if you don't have a heated plugger and you like a bit of root canal and you've got no root canal instruments, this is the first thing you're going to buy for sure. So it's got so versatile. Once the excess has been cut off, we're going to compact the GP cone down with a Mach 2 plugger. And I used to be a little bit ginger about this, but now I know the end of the tooth has been apically gauged properly, so I'm not going to be shy. I'm going to really, really push down with the Mach 2 plugger. And what I do say to the patient here, you can see that I'm pushing down quite firmly with my finger. As I say to the patient, I'm going to push down firmly, and then I push really, really hard as a final sort of compaction. And then we're just going to clean the access cavity with an ultrasonic. Great thing about the bioceramic is you can remove it really easily with water. And once we've cleaned the access cavity, we can see here now that the canal orifice has been filled really, really well with our GP. And it's at this point now we need to seal this GP off, because this tooth is quite badly broken down, and the restoration needs a kind of bit of a backstop. So I'm gonna seal the orifice with light cured GIC. So in this case, I'm doing a bit of Vitrebond, and I'm using these Acidose tips, so fantastic little tips. So I'm just going to mix this GIC with just a paper pad and a metal spatula, and then I'm just going to pick up this Acidose tip here. And these are great because you can fill these with anything you liked, but you manually load this with whatever you like, and then once you've placed the material into the Acidose tip, you get this kind of little rubber plunger, and then this will go directly onto your composite gun, and then you can really, really directly and accurately place the GIC exactly where you want it to be. So there's no other way of placing GI as accurately as using these little tips. So you can see here now that when I introduce this tip into the canal orifice, You know, I am just very, very gently just pushing this GIC into the canal orifice, and then we're ready to light cure it. And then once the GP cone is nice and sealed, I'm just going to use a self-etching bond. I'm just using Scotch Bond, and then SDR, and this is kind of a bulk flow composite filling. And we look at the X-ray, and it looks really, really nice. We've got a tiny little bit of a sealer puff. Again, I've noticed on a couple of social media accounts where people are really concerned about sealer puffs. I think in the main, I want to avoid a sealer puff, but, you know, especially with a bioceramic, I know that I've filled the end of the tooth. Again, I think if I'm being very, very, very critical here, I believe there's a little bit of decay distally at this tooth. Not ideal, but I still think the tooth is certainly restorable. And overall, that's the case. So thanks for watching. If you have any criticisms, if you have any questions, if you got any burning things you want to say, don't be afraid to place it in the comment section below. Again, if you completely disagree with everything I've done this appointment, just comment and let's have a discussion. There's no egos here. I've learned so much from the viewers. And, you know, again, if you want to support the channel, please like and subscribe. We've also got the membership program. We've got early access to content. We've got exclusive content. We've got a fantastic endodontic access lecture. And all I want to say is thank you for watching, and I will see you next week in the next video. Goodbye.